Good afternoon, everyone, and welcome to today's webinar entitled Pediatric Organ Donation and Donor Management. We're so glad that all of you could join us as we have a wonderful presentation in store for you today. My name is Deanna Fenton, and I'm the Program Manager for the Alliance. Now, we do have just a few logistical items to review before we begin today's presentation. For those of you who have never joined us on this webinar platform before, the chat feature is located in the bottom left-hand corner of your screen. Now, we are recording this webinar, so we will not be opening the phone lines during today's presentation. That means that all questions must be submitted electronically using the chat feature. If you have any questions that come up during the webinar, please feel free to submit them at any time. Once the presentation is complete, we'll have some time for our presenters to address as many of your questions as time allows. Now, registration is currently open for our next webinar entitled Navigating the Waters of Post-Transplant Nutrition, How to Help Patients Stay Afloat. That's coming your way on February 28th at 3 p.m. Eastern. Registration is also open for our upcoming webinar entitled Missed Signals, Navigating a Difficult Phone Conversation. So be sure to tune in for that on March 12th at 2 p.m. Eastern. Now, for those of you who may be interested in continuing education credits, we are offering 1 CEPC credit and 1 nursing contact hour, courtesy of Donor Network West, for today's webinar. Everyone listening is entitled to claim continuing education credits. If you are listening in a group, as many of you are, please make sure to get the evaluation email from your group lead. It's a very brief online evaluation which will allow you to receive your credit. Now, as a reminder, for nursing, you have 14 calendar days to claim your credits, and for CEPC, you have 30 calendar days. At this point in time, I'd like to introduce our moderator, Marty Sellers, OPO Medical Director at LifeLink Foundation of Georgia. Marty, we're so glad that you could join us today, and at this point, I'll turn it over to you to introduce our speaker.
Great. Thank you, Deanna. And it's a pleasure, and I'm excited actually to be the moderator for this session. I'm not sure if any of you have heard Dr. Nakagawa speak before. I've had the good fortune of doing so, and he is, it's obvious that he has a very strong command of the subject, and he presents it extremely well also. There are a couple of background slides I'll just provide from sort of a 30,000-foot view with respect to how UNOS views children. And UNOS, as well as Mother Nature, pediatric patients are not just small adults. The UNOS definition, as you're probably aware, includes anyone that is 17 years old and younger. And because of the fact that they're not just small adults, there are unique considerations that go into the transplant side and the organ donation side when it comes to the pediatric population. This was recognized early in our field, and the National Organ Transplant Act of 1984 even includes the verbiage that it challenges the OBTN to recognize the differences that exist between children and adults when it comes to their organ failure and transplant issues, and to adopt criteria, policies, and procedures that address these unique healthcare needs of children. From a physiologic standpoint, children have much less effective life-sustaining therapies. If you take someone that is trying to be bridged to heart transplantation, for example, the bridge to transplant modalities for heart failure in children are fraught with complications and are less likely to be successful as they are in adults. From a pediatric renal failure standpoint, vascular access for hemodialysis is challenging, to say the least. If you're a child on dialysis, you might live a long distance from any dialysis unit that has expertise in the dialysis unique needs of children. On top of that, children are, the clock is ticking from day one, and they have a time-limited opportunity for growth and development. So if we don't intervene and intercept the negative consequences that go along with organ failure in children, then these consequences are lifelong and they can be devastating. Some of which, just a few examples, are cognitive delays, delayed puberty, doctor visit, and illness-related absence from school obviously interferes with their academic progression, isolates them socially, has self-esteem issues, anxiety, depression. All those things stem from the fact that these children just are not afforded an average, normal, everyday life. So because of that, early transplantation is really important. It gives them back some of the things that they haven't been given because of the organ failure, including, number one, the best chance that they have of having of a healthy childhood, and then, as an extension of that, the best chance of leading a productive and fulfilling life. So because of that, the Ethics Committee, there's a white paper from the Ethics Committee in UNOS, and this is just quoted from their white paper, that there is a reasonable basis for giving preference to pediatric transplants for allocation. Some in the adult world have questioned the preference that children get in the allocation schemes, but I think these are easily justified if you look at the ethical principles of justice, equity, and utility. And we could have a series of webinars on ethics of pediatric transplantation, but I'll just refer you to the document that's referenced at the bottom of the slide that is really well done in terms of how to justify and the ethics, the principles that are associated with the preferences afforded to children on the waiting list. If you just look at the current policy, children are given preference to the high-quality kidneys. A KDPI of less than 20%, if you don't already know, means that you're getting a kidney from, or you're getting a top 20% kidney in terms of long-term outcomes. And these kidneys are preferentially allocated to people that have the longest estimated post-transplant survival, which by definition includes children. Currently, the liver allocation scheme, and I won't go through this in detail, but you can see that the nation is exhausted for pediatric status 1 candidates before it's ever offered to any adult if the donor is less than 11 years old. If they're less than 17 but greater than 11 or 11 or greater, then the first adult that's not a status 1 comes up in sequence 9. In the future, with changes coming in the liver allocation scheme in just a few months, it's going to even further advantage children in such that any pediatric candidate within a 500 nautical mile radius of the donor hospital will be offered the liver prior to an adult. And if you just look at what's been fair across the history of transplantation, or at least the last 30 years, you can see the percentage of donors each year that have been pediatric has far exceeded the number of recipients. So children actually have offered or contributed more organs to the system than they have taken. It's fortunately decreased over the course of time, just from child safety laws, et cetera. But still, even in the year 2018, there were far more kidneys or far more organs donated by children than were used by children. If you just take the collective last 31 years of the previous slide, it still shows that over half, or more than twice as many recipients have, or I'm sorry, more than twice as many organs have been donated by children than have been taken. So because of, and that's sort of the 30,000-foot view of the world we live in the pediatric transplant world. More details, again, I'm looking very forward to Dr. Nakagawa. In case you're not familiar with his resume, as you see on the slide here, he's at St. Petersburg All Children's Hospital, Johns Hopkins All Children's Hospital in St. Petersburg, and he is an international leader, thought leader, and an excellent presenter on this topic. So Tom, with that, I will hand it over to you, and thank you very much for your contribution today.
Great. Dr. Sellers, thank you. Good afternoon, everyone, and I guess it's still good morning to those on the West Coast. I do want to thank Leanne Swanson and Dr. Sellers for inviting me to participate in this webinar this afternoon and giving me the opportunity to talk to you about pediatric organ donation and donor management. The death of a child is a rare event, and it's a tragic event that profoundly affects and disrupts family stability, and it impacts the medical team as well. Organ donation provides an opportunity for families to allow the legacy of their child to live on after death has occurred, and that inevitable death of one child is juxtaposed to the preventable morbidity of another child or children who may die or become disabled waiting for a life-saving organ transplant. Additionally, we know that organ donation can help provide comfort and help families heal. If we look at mortality rates in pediatric critical care units across the United States, they typically range around 3 to 5%. And the majority of deaths that are occurring in intensive care units throughout the world, not just in the U.S., but throughout the world, occur following withdrawal of life-sustaining medical therapies. There are fewer adults and fewer children that are admitted to hospitals across the United States that are dying as a result of catastrophic neurologic injury. Especially in children, these smaller numbers make pediatric organ donation a rather rare event. Professional medical organizations such as the American Academy of Pediatrics, Society of Critical Care Medicine, and American Heart Association actually all support organ donation as a part of end-of-life care. Now, if we look at donation transplantation data, in 2018 there were 10,722 deceased organ donors. If you do the math, that works out to roughly 27 adult donors per day across the United States. In 2018, 875 of those donors were children. That equates to 2.4 pediatric donors per day across the United States. Pediatric donors make up about 8% of all the deceased donors. Now, if we look at the transplants from deceased organ donors in 2018, there were almost 30,000 transplants from deceased organ donors, and of those, 1,559 were pediatric transplants. That means that 5% of all organ transplants from deceased donors in the U.S. occurred in children. And while many children were successfully transplanted, as well as adults, there are still children and adults who die waiting for a needed organ. Now, if we look at the waiting list data, there's currently over 113,000 candidates on that wait list, of which 1,935 are children. That equals about 1.7% of the total wait list. The deaths on the wait list for 2018 were over 5,000 deaths for a death rate of around 4.5%. There were 115 children that died in 2018 for a 6% death rate. So the death rate for children waiting for a needed organ is actually higher than adults. And if we look at this closely, there's about 130 children that die annually waiting for a needed organ. This includes probably 50 to 60 children that are removed from the national wait list because their condition deteriorates to a point where they get so sick that they can't be transplanted. There are other issues that we deal with in pediatrics too, as far as challenges. Challenges such as size restrictions of pediatric donation and transplantation. The decreasing incidence of children dying from neurologic death, high mortality rate in infants awaiting heart transplantation, and the need to match age and size recipients, which is one of the primary reasons why children less than 1 year of age have the highest death rate waiting for an organ. It's hard to find those organs, and it can also be technically challenging to actually transplant those organs. Unfortunately, we continue to have missed opportunities for donation. And because of the small number of potential donors, especially children, the opportunity for donation has to be maximized in every situation. Because when a child dies, or for that matter, when any person dies, if we miss an opportunity for donation, that means somebody on that transplant waiting list dies as well. There's a number of reasons that we have missed opportunities for donation. Timely referral to the OPO may not occur. And again, this really is important to stress that we need to be working with our hospitals to ensure referrals occur in a timely manner so adequate time is allowed for donation and end-of-life care discussions. And this still remains one of the best practices for successful authorization for organ donation. Families of potential organ donors may not be given the opportunity to donate. In fact, many times medical personnel may feel the patient is too sick. Medical personnel also don't understand that donation coordinators can actually work to improve organ function and make organs suitable for transplantation. Families may actually deny donation. They may be approached at the wrong time. They may lack trust in the medical system. A family's belief in donation also affects their decision to allow their child to become an organ donor. And in many instances, the family has not come to the realization that their child has died, which results in a denial for donation. The options for donation may be denied in cases of homicide. This is especially true in abusive trauma cases in children. ME and coroners, as well as prosecutors, fear loss of evidence or inability to successfully prosecute perpetrators in these cases. And in fact, there's no case law that's ever been on the books where that has occurred. And then importantly, patients may not be aggressively managed following a critical injury or illness, and this includes management prior to death and also following death. The medical management of any patient should continue until discussions have occurred between the medical team and the family to ensure that we establish limits of care and resuscitation issues. Just because a patient has a DNR order or a DNR status doesn't mean that the patient doesn't receive medical treatment. Unfortunately, DNR still continues to be used as a surrogate for medical treatments. DNR only establishes treatment when a patient has cardiopulmonary arrest. DNR does not mean do not treat. Finally, organs can be damaged during surgical recovery for transplantation, and this really emphasizes the importance of utilizing the most skilled pediatric surgical specialists who are knowledgeable and have the technical ability to surgically retrieve organs, especially from some of our smaller infants and pediatric donors. So with that introduction, my objectives today really are to identify special circumstances that influence care of the pediatric donor and recovery of organs for transplantation. We're going to talk about the physiologic differences between children and adults. We'll also review important aspects of donor management in children, including hormonal resuscitation and donor management goals. And then we'll briefly talk about donation after circulatory determination of death, or DCD, in children. Now, there are some special circumstances regarding pediatric donation. As I said, pediatric donation is rare. With an average of only 2.4 pediatric organ donors a day across the United States, there's many physicians, medical teams, and donation coordinators that will have little exposure or maybe no exposure to actually managing a pediatric organ donor. Medical management of that pediatric donor requires expertise and understanding of the physiologic differences that exist between children and adults. And it's important, as Dr. Sellers pointed out, children are not small adults. And this is especially true for infants and smaller children. Now, the older child, the adolescent, physiologic aspects of drug dosing and physiology and anatomy are very similar to that of an adult. But the smaller infants, neonates, toddlers, they are not small adults, and they require a skilled team to manage these specific aspects of pediatric medical care. Now, that management of the pediatric organ donor requires a team of skilled medical personnel who are uniquely trained in that special or specific aspects of pediatric medicine and skilled at working with children and families. Importantly, the team composition that we deal with when we admit a critically ill child to an intensive care unit is different from the team that we utilize when we're dealing with a child who is dying in the intensive care unit. And when we're talking about end-of-life issues and management as a donor, many times we're dealing with a different team, a different group of dedicated individuals that are caring for this child and family. And that includes not only just the physicians, but nurses, respiratory therapists, social workers, chaplains, translators. Child life specialists are very important because somebody has to sit down and talk with the siblings and let them know that their brother or sister isn't going to come home that day. Donation coordinators, the transplant team, and of course our administrators, because we have to have administrative support. There are, excuse me, as I mentioned previously, anatomic and physiologic differences in children because they are not small adults. There are significant anatomic and physiologic differences between infants, small children, toddlers, and adults. And these differences become less important with adolescents, for many times the anatomy and physiology are the same as an adult. But in infants and small children, the airways are actually smaller. And the importance of this is that it results in increased airway resistance. The disease processes are different. Our chest wall is more compliant. We have less developed respiratory muscles. If you think about the disease processes for infants and smaller children, they don't typically have bronchitis like adults. They have diseases like bronchiolitis. We look at the cardiovascular system. It's less mature, and infants and smaller children have a higher resting heart rate to maintain cardiac output. As a reminder, cardiac output is heart rate and stroke volume. So you have a small heart that can only generate a certain stroke volume. In order to maintain cardiac output, you have to make that up with heart rate. And this is why drastic declines in heart rate can significantly affect cardiac output. It's important to understand normal heart rate and blood pressure parameters because they differ by age. And as we look at this slide here, you can see neonates, infants, toddlers, school-age children, and adolescents. And you can see the heart rate drops and your systolic and diastolic pressures rise as you get older. So as the child's body matures, vascular changes allow for increased pressure and a resultant decrease in the heart rate. And it's important to understand these vital sign parameters because unlike adults, you can't use a single mean arterial pressure to be used for every child. A mean arterial pressure of 90 millimeters of mercury might be reasonable for a 17-year-old or an adult, but in a 17-month-old, it's massively hypertensive. Other important anatomic and physiologic differences include the larger body surface area, and that results in rapid heat loss and temperature instability that can be further exacerbated with neurologic death since the midbrain is no longer functional. There's limited glycogen stores, so these kids are prone to hypoglycemia. They also have limited catecholamine stores, especially in the smaller infant. That's why children hang on to their blood pressure until the catecholamines are depleted, and then they become hypotensive. So when you start to see that rising heart rate and falling blood pressure, they're indicators of an evolving cardiac output issue and the development of a low cardiac output state that requires immediate intervention. Additionally, children are neurologically different from adults. It's interesting because in the newborn and in the child less than 1 year of age, the brain has a much higher water content because myelination of the nerve fibers hasn't occurred. As the child gets older, that brain takes on much more of a consistency like an adult brain. The subarachnoid space is larger, and that means that the brain can move around inside the skull more, and this is what's commonly seen in abusive head trauma, or what the lay public knows as shaken baby syndrome. This is why it's so detrimental to have that increased mobility of the brain inside the skull, because it does put small children at risk for bad head injury. And then, of course, psychologically, kids are different from adults as well. There are special considerations that are important to take into account with pediatric organ donors. There's the emotional aspects following the death of a child, and this is not just the family, but it's also the medical team that grieves with that family. An essential part of care provided to children and families are trained staff who understand those unique needs and issues related to children and their families. Important clinical management issues include size limitations that can restrict transplantation of organs. We have technically challenging procedures in small children, and then we also have equipment needs that are different. So we have airway and vascular access or catheters, endotracheal tubes of various sizes that are used based upon the size and the age of the child. Vascular access can be extremely challenging in small pediatric patients or an infant, and Dr. Seller has alluded to this with dialysis, but peripheral IVs have a limited lifespan, and trying to place a peripheral IV into children who are edematous with fragile vessels is not always easily accomplished. Central venous and arterial cannulation can also be challenging in a critically ill child, and many times when coordinators come on site, they may only have a double lumen central venous catheter to infuse medications and blood products through, compared with an adult donor where you may have 2 or 3 multi-lumen central catheters and peripheral IVs for infusion of medications and blood products. So when you walk in and say, well, gee, we need another IV, can you put a peripheral IV in? Easier said than done sometimes. So preserving your line access is essential when managing a pediatric donor, and understanding drug compatibility issues is essential as well, because if we mix the wrong drugs together and we get precipitation in the line, then we lose a port. Additionally, fluid administration may be limited by those smaller catheters and peripheral IVs. Dosing of pharmacologic agents in children is typically weight-based. The ideal body weight should be used for obese children, and unfortunately childhood obesity is a problem in our society. Ideal body weight can be determined from pediatric growth charts. It's important to remember that administration of continuous infusions, especially in smaller kids, may require concentration of medications to avoid administering excessive fluids to a small child. For instance, you can't have a 3-kilo baby and have epinephrine running at 15 cc's an hour, because it exceeds the normal maintenance fluids for that child. So we have to be creative with our administration of medications. Importantly, once a child reaches 40 kilograms, some institutions use 50 kilograms as a cutoff, the adult-based dosing guidelines should be used. The limited vascular access and multiple infusions can also pose issues with drug compatibility, as I've talked about. So it's essential to preserve that vascular access, because if you lose a single lumen in a 2-lumen catheter, you can really severely limit the ability to provide ongoing infusions or doses of medications that are needed in an effort to try and get those organs to the operating theater. Pharmacokinetic activity can be affected by organ system dysfunction, and this includes renal and hepatic insufficiency or failure. It's important to take those things into consideration as we're dosing medications. Hypothermia can also alter drug metabolism, so thermal regulation is important. for any patient, but especially those with end organ dysfunction or failure. And this is where continued consultation with a pediatric intensivist and involvement of a pediatric pharmacist working closely with that bedside nurse are essential in the management of that pediatric organ donor. Now, once a family has authorized donation, providers really should sustain focus on achieving recovery of as many organs as possible to help as many individuals waiting for that needed transplant. Families and staff need to be prepared for the shift in goals of supporting and saving the life to actually organ preservation. And while the goals and the interventions may change, the degree of attention and vigilance to the plan of care and the patient needs shouldn't change. After neurologic determination of death, medical care of that donor is really dedicated to correcting a multifactorial shock state, and it needs to be driven by critical care specialists in conjunction with the donation coordinators. National and international best practices for deceased donation emphasize that management of the potential donor, whether it's adult or pediatric, really is a continuum of care that preserves the option of donation after declaration of death. And that's why management of that pediatric donor requires the collaboration and the expertise of the intensivist, the critical care team, the donation coordinator, all working together as goals of care shift from saving the life to preserving organ function for organ recovery. And that shift in goals really needs to be seamless with ongoing medical care that provides a continuum of care from admission to recovery of organs in the operating theater. Now, the management of the pediatric organ donor is going to be dictated by regional standards of care and the physicians caring for the child. Importantly, children are best cared for in a pediatric center with trained staff who are familiar with children and families and skilled in pediatric medicine. Now, there may be instances where a child cannot be transferred to a tertiary or quaternary care pediatric facility, and in those instances, consultation with a pediatric intensivist, such as myself, should be considered to assist with management issues and to help guide you so that you're not fluid overloading or putting the wrong inotrope or actually potentially harming organs when we're trying to preserve organ function and salvage those organs. So that's why the consultation with that intensive care specialist and other pediatric specialists is paramount to ensure the best recovery of organs. Our management goals include restoring normal physiologic function of organ systems, and that requires us to resuscitate the donor many times to improve organ system function, and then we have to maintain oxygen delivery to the tissues, and we have to restore and maintain hydration, perfusion, normal ventilation, thermal regulation, neuroendocrine function, and we also have to continue support for the family, which is essential. The caliber of the trachea changes as a child grows, and airway management is key in the pediatric patient. And I'm going to focus on a couple of specific areas which are unique to pediatrics. An appropriate size endotracheal tube needs to be placed to maximize ventilation and airway clearance of secretions and debris. A cuffed endotracheal tube should be used to protect the airway from aspiration or oral or stomach contents. Now, if the patient doesn't have a cuffed endotracheal tube, the request should be made to the intensivist to replace it with a cuffed endotracheal tube. And that cuff or the balloon should be maximally inflated. The goal is to protect the lungs from any type of aspiration. Now, the respiratory therapist may challenge the increased balloon pressures because of altered microcirculation, but it's really irrelevant because the goal is to protect the airway. The trachea is not going to be recovered, and alteration of the microcirculation for that short period of time is not going to be an issue. The head of the bed should be elevated. Appropriate clearance of secretions with good pulmonary toilet should be utilized to maximize potential for lung recovery. And this requires collaboration with the ICU team, including our respiratory therapist, which can help develop a plan for airway protection and clearance of secretions. A chest radiograph should confirm placement of the endotracheal tube above the carina. And especially in infants and small children, the difference between 1 centimeter can mean the difference between being in the right main stem bronchus or actually having an endotracheal tube that's above the vocal cords, and now you have an extubated patient. The tip of the endotracheal tube should actually reside between T3 and T4. The carina typically branches at T5, so when you're looking at x-rays, even if you can't see the carina, typically around T5. Our donor management goals for oxygenation and ventilation include maintaining PaO2 greater than 100 and normalizing our CO2 in the range of 35 to 45 torr and maintaining our arterial pH in a relatively normal range. We want to try and get our oxygen levels down to about 40%. That's a nice safe level. High concentrations of oxygen can potentially damage the lungs. 40% is a nice safe range to be in. I don't usually go below 40% because this provides an oxygen reservoir if there's a situation that results in hypoxia, such as mucus plugging or the endotracheal tube gets kinked. A protective lung management strategy is used by many intensivists where we're using lower tidal volumes and higher end expiratory pressures, although some people still ventilate with larger tidal volumes and lower end expiratory pressures. So it's important to consult with the intensivist and the pediatric respiratory therapist to help develop appropriate ventilator settings to reach oxygenation and ventilation goals and maximize lung preservation for potential transplant in older children and adolescents. I will tell you that children under 5 years of age, it's extremely rare to be able to recover those lungs. I'm not saying that it doesn't happen, but it's extremely rare. We look at our hemodynamic goals. Arterial and central venous access with frequent monitoring of the cardiovascular status is required. We have to have serial clinical examinations, serial lactate measurements, and some places use central venous oximetry as well. Our volume administration, inotropic support, or vasopressor support are frequently required to treat hemodynamic instability and maintain adequate perfusion to end organs. It's important to understand the clinical endpoint for us is volume administration and titration of inotropic support for hemodynamic stability. We want to avoid that hemodynamic instability and normalize our blood pressure. And our normal blood pressure is based upon pediatric advanced support guidelines using the formula 80 plus 2 times the age in years as the appropriate systolic blood pressure. Some people use a mean arterial pressure as well, but the PALS guidelines support systolic blood pressure. The lowest acceptable systolic blood pressure is determined by using the formula 70 plus 2 times the age in years. Now, it's important that we don't just treat the number because lower blood pressures may be acceptable if biomarkers for tissue perfusion such as serum lactate or SpO2 monitoring are normal. While the systolic pressure is important, if biomarkers and other non-invasive monitoring allow you to maintain a lower blood pressure with good end organ perfusion, allowing for less fluid and vasopressor support, then we may actually help those donor organs become better for the transplant recipient instead of using more volume, overloading the patient, and ending up with edematous organs. Now, one of the things that we use in pediatrics is called near-infrared spectroscopy monitoring. Our conventional cardiovascular monitoring may not detect tissue hypoxia despite our efforts to improve cardiac output and cardiovascular support with fluids and vasopressors. Near-infrared spectroscopy is a continuous non-invasive monitoring device that looks at tissue oxygenation, and it's commonly used to measure cerebral oxygenation in patients undergoing cardiac surgery. There's extensive experience with the use of NIRS in pediatric patients, and this non-invasive technology actually allows us to determine tissue oxygenation and respond more quickly than conventional biomarkers. NIRS monitoring for cerebral oxygenation isn't useful to us in the brain-dead patient because they're brain dead. However, somatic NIRS can provide us with regional tissue oxygenation or tissue saturations in the renal bed, allowing us to tailor our fluid and vasopressor support accordingly. So we may be, again, able to reduce our inotrope, reduce our fluid load if our renal or splanchnic tissue oxygenation is actually reasonable using NIRS monitoring. And I think this is important because we tend to treat these numbers. As an example, just because we have good oxygen saturations by pulse oximetry, it doesn't mean that tissues are receiving adequate oxygen delivery. You can have a good saturation but still have poor oxygen delivery with an elevated lactate level. For hemodynamic instability, many OPOs routinely rely on hormonal replacement therapy to optimize cardiac output and augment treatment for cardiovascular instability. And the use of high-dose corticosteroids, vasopressin, thyroid hormone are typically used by many OPOs. There's really no good published studies that specifically address HRT in pediatric donors, although large retrospective adult cohort studies suggest increased organ utilization with hormone replacement therapy. We do know that HRT does allow us to actually wean vasopressors in pediatric patients. The management of the unstable pediatric organ donor who isn't responsive to conventional treatment using fluids and inotropic support really warrants the use of these hormonal cocktails. In an abstract that was presented 11 years ago at the Pediatric Summit for Organ Donation, Sharif and colleagues actually reviewed over 1,900 pediatric donors, and they compared those donors who received hormonal replacement therapy with a 3-drug combination of corticosteroids, vasopressin, and thyroid to those who did not receive any type of hormonal replacement therapy. And what they found is that with the use of 3-drug combination therapy, they had a significant increased odds of pediatric donors having their livers and at least one of their kidneys and lungs transplanted. So I think that there is some validity to utilization of hormonal replacement therapy in pediatric patients. It doesn't necessarily benefit the donor. I think what it does is it helps condition and gives a better organ for the transplant recipient. Fluid and electrolyte disturbances are commonly encountered in the brain-dead donor. Our neuroprotective strategies used prior to death commonly result in volume depletion due to fluid restriction. You have osmotic diuresis, and you can have diabetes insipidus. And the osmotic diuresis that we see can be from agents such as mannitol, but it can also be from uncontrolled hyperglycemia that can contribute to an osmotic diuresis as well. Diabetes insipidus can occur during progression to neurologic death, and that can further exacerbate fluid and electrolyte disturbances. And it really requires prompt management to prevent deterioration to cardiovascular collapse. Volume resuscitation to restore euvolemia and aggressive management of DI need to be initiated, including urine replacement therapy and the use of antidiuretic hormone or vasopressin. The treatment of hypernatremia and hypovolemia becomes important, and it requires volume resuscitation and replacement to make the patient euvolemic. Hypernatremia should be aggressively treated with fluid replacement and pharmacologic treatment to correct the diabetes insipidus. The rapid correction of that hypernatremia is irrelevant. Some will say it causes cerebral edema, but it's of no concern because our patient is brain dead. The ongoing urinary losses from DI requires aggressive management to prevent further organ system deterioration. And so we're going to treat these patients aggressively with one-to-one renal replacement or renal output replacement with a hypotonic IV solution to replace that free water loss associated with DI. Again, pharmacologic correction using either desmopressin or vasopressin is utilized in these situations to help control urine output. The clinical endpoint for the treatment of DI is really to decrease urine output, not completely stop urine output. And again, we want to normalize our serum sodium probably in the range of 130 to 150 milliequivalents per deciliter. And this is, again, accomplished using fluids, fluid replacement, and pharmacologic agents. Vasopressin and desmopressin really should be titrated to decrease urine output to a manageable level, which is typically around 3 to 4 cc's per kilo. Vasopressin is preferred by many OPOs because of the short half-life, and it has the ability to potentially allow weaning off vasopressor support in some instances. People shy away from desmopressin. Desmopressin is actually more potent on a weight-for-weight basis than vasopressin is. It does have a longer half-life, but it's very good at controlling DI, especially when you have DI that's refractory to vasopressin. So you may need to actually combine these two drugs in an effort to control refractory diabetes insipidus. In some instances, brain-dead patients can be massively fluid overloaded. They can also have severe metabolic disturbances such as hyperkalemia from renal failure. Invasive procedures, including dialysis for fluid removal and electrolyte imbalances, have been utilized in extreme cases. The use of extracorporeal support in the brain-dead donor has also been considered in extreme cases where hemodynamic instability is so severe that they need a bridge to organ recovery. Other important management considerations include glycemic control. Hyperglycemia can exacerbate that osmotic diuresis, and so we really want to try and keep our glucose within normal parameters. The use of insulin to control hyperglycemia is important. It's important not only to keep the serum glucose levels in a relatively normal range, but also to help move glucose into the cell for energy utilization. Now, it's important, especially in the smaller infants and children, that hypoglycemia can develop very rapidly, and this is because they have limited glycogen stores. So if we're using insulin infusions in these smaller kids, we really need to be following our glucose levels very closely so we avoid hypoglycemia. Calcium regulation is important too, and it plays a very important role in infants and smaller children because calcium can actually act as an inotrope and enhance myocardial contraction. Now, many of the patients that we deal with post-death like this are hypoalbuminemic because of volume resuscitation. And when you're hypoalbuminemic, your total calcium levels are probably going to be low as well. In these instances, we really should be following our ionized calcium levels with a goal of trying to keep that ionized calcium level in the range of 1.1 or 1.2, as a rule greater than 1.0. It's important to remember also that when large amounts of albumin are administered, albumin will bind calcium and can actually result in hypotension if you're calcium depleted. So IV calcium chloride or gluconate can replace that calcium and improve myocardial contractility. It's important to remember that calcium chloride should be administered through a central line as it's extremely caustic to those peripheral veins. We want to make sure that we're correcting and maintaining normal hematologic and coagulation parameters, and this is especially important before you go to the OR. Antibiotics are commonly administered prior to going to the OR, and control of thermal regulation is important following neurologic death since patients basically become poikilothermic. The other thing is if you're really, really hypothermic like that, it can affect coagulation as well. This slide presents us with donor management goals shown on the table. And again, to summarize, our goals of care include normalization of our blood pressure for age with minimal use of vasopressor agents and avoiding fluid overload. Normalization of oxygenation and ventilation parameters. We want to keep the fraction of inspired oxygen around 40% and keep our PaO2 greater than 100 millimeters of mercury. PaCO2 and pH should be normalized, and we want to avoid hyper or hypocarbia. The normalization of electrolytes, glycemic control, ionized calcium is also important, and again, thermal regulation to maintain normothermia is important. The algorithm that I typically utilize for blood pressure management is if a patient is hemodynamically stable, they'll typically receive steroids, thyroid hormone, and either desmopressin or vasopressin if they have diabetes insipidus. For the hemodynamically unstable patient, those patients end up getting volume loaded. You start an inotrope or vasopressor support. Steroids are administered. Thyroid hormone, including a bolus of thyroid hormone prior to the maintenance infusion, will be administered so that you can try and get those levels up and stabilize the hemodynamics. And then DI in these cases is treated with vasopressin to help augment cardiovascular support. So again, the hemodynamically unstable patient is more challenging, but does require volume loading and vasopressor support. In the hemodynamically stable patient, I typically do not bolus with thyroid hormone. Donor management goals are important because they increase the number of organs recovered for transplantation, and this has been borne out in adult studies, but studies in children are lacking. In an abstract that we presented from 2 OPOs in the state of North Carolina, over a 5-year period, we looked at 148 pediatric brain dead donors. And what we found is if we met greater than 80% of the donor management goals, we recovered 1 more organ per donor compared with patients where we didn't meet 80% of those donor management goals. And I think this is important because if we didn't meet those donor management goals, we would have lost potentially 148 organs, or at least a percentage of that. When we look at donor management goals, it makes sense that if we meet our donor management goals, we're actually providing good care to the donor. Importantly, children typically have or are very healthy prior to death, and so they have healthy organs, and we need to make every effort to recover those organs. Now, as Dr. Seller stated in his introductory slides, unfortunately many organs go to adults, but there are more organs that are being transplanted into children. Unfortunately, though, many organs from children don't get transplanted, one, because they're too small, or you can't find a recipient that's the right size match for that particular organ. I want to spend just a minute talking to you about pediatric DCD because this is an important area of growth as it targets the 2 most needed organs for children, which are liver and kidneys. And as we're all well aware, DCD requires extensive collaboration with our colleagues in the ICU, OR, and the OPO, and also the family to ensure that we have successful outcomes. Pediatric DCD donors are a small percentage of all donors. However, children continue to make up about 8 to 10% of the entire DCD pool in the United States, donor pool in the United States. And although a single institution may only have 1 or 2 cases per year, the effect that this has on a national level when you add this into multiple hospitals results in the recovery of a substantial number of organs. And these organs are actually being recovered and transplanted with good success. One of the other areas that's important is the area of neonatal donation opportunities, and this is where we need to be working with our colleagues in neonatology. Death by neurologic criteria is rare in neonates, but there are increasing opportunities for neonatal donation following circulatory death because, again, the majority of deaths are following withdrawal of medical therapies. We have recovered en bloc kidneys, liver cells. The liver has been processed. The cells are then transfused back into children with metabolic liver disease, and specifically those children with urea cycle defects. And these liver cells actually take up home in the damaged liver, allowing the child to grow until they're large enough to receive a liver transplant. And this therapy can be life-saving for those children. Neonatal heart recovery has occurred from neonatal DCD donors as well. The use of anencephalic infants has some renewed interest, and in an abstract that we presented at the International Society of Organ Donation and Procurement, in conjunction with my colleagues in California, Utah, and Virginia, we collectively looked at anencephalic infants as DCD organ donors. We identified 17 anencephalic donors. Organ recovery was attempted in 4 or 5 infants. Viable organs and tissues were recovered from 4 infants. We had 2 livers, 2 kidneys, and 2 sets of heart valves. Now, only 2 kidneys were recovered and transplanted, and the livers were used for hepatocyte transfusion research, as I just talked about. Now, some of you are probably shaking your head thinking, wow, the numbers are really small. Why would we even want to pursue something like this? But I would remind you that the numbers were small when organ recovery from pediatric patients following neurologic death was first introduced, as was the case with pediatric DCD donation just 10 to 15 years ago when we started to recover more organs from pediatric donors following circulatory death. Last, I want to talk about our medical examiner denials because the medical examiner denials continue to result in lost organs available for transplantation. There's somewhere between probably 130 to 150 ME denials across the United States annually, and that can result in the loss of potentially 600 organs that could be transplanted. ME denials really plague us, but it's important to understand that ME plays an important role in determining if death was intentional versus accidental, and so we have to work closely with the ME and our law enforcement and investigative teams and our pediatric specialists to determine that mechanism of injury. Because as pediatric specialists, our job is to advocate for children. And if a child who's intentionally harmed dies and we allow a perpetrator to avoid prosecution and harm another child, then we have failed in our mission to protect a vulnerable population of patients, even though we recovered organs and saved lives through transplantation. So close collaboration and working with ME is essential to ensure that we can recover organs, that we can successfully prosecute perpetrators who abuse children. Some final considerations. It's imperative that you consult with the pediatric intensivists, the pediatric specialists, and collaborate with the pediatric critical care team to ensure the best possible outcome for donor organs and the recipient. This is not really a turf battle. This is about all of us mutually respecting one another and collaborating together for the individual expertise that we offer at the table. And when we combine those results in a coordinated care, we get the best outcomes. And our outcomes really and what we do should be vested in the interest of the donor, the family, and the transplant recipient, not necessarily the turf that we walk on. So I really encourage you to work with your intensivists, work with your critical care teams, find those champions, okay, develop care plans together, develop a consistent team of people that can work with the pediatric intensive care team to help save more lives and recover more organs from pediatric donors. I want to thank all of you for taking time out of your busy day today to allow me to provide some insight into pediatric organ donation and donor management. I hope that I have provided you with some useful information that will help you next time you encounter a pediatric donor. Pediatric donors, remember, are rare, but they do occur, and we have to maximize every potential opportunity. As always, I remain available to the donation and transplantation community as a resource. And to all of you, thank you for the great work that you continue to do to save more lives through donation and transplantation. Thanks.
Thank you, Dr. Nakagawa, for such a wonderful presentation. Before I turn it back to Marty to moderate the questions, I'd just like to remind everyone that if you do have any questions for both of our presenters, please feel free to submit them using the chat feature. Again, the button or icon is located in the bottom left-hand corner of your screen. Also, during the Q&A session, I will have this poll up. For those of you who are listening in a group, if you don't mind completing this poll to let us know how many people are actually listening in your group, that would be greatly appreciated. Okay, that being said, at this point, I'll turn it back over to Marty for your questions. Thank you.
Deanna, thank you very much, and Tom, as always, excellent presentation. I don't see any questions yet from the audience, but please type those in. While we're waiting on that, Tom, just in the adult world, we use, or I hear from the coordinators on site, we have the patient on dopamine, and when you mention the word dopamine to an adult intensivist, they look at you like you're from the 1980s. Is that something that we should be not using as much as we do, and do we use it as much in the pediatric world as seemingly happens in the adult world?
Dopamine is still a mainstay as far as a vasoactive agent or an inotrope in pediatric patients. And so we still do use a lot of dopamine, especially in the smaller patients. In the adolescent age group, a lot of times we're going to be using agents like norepinephrine. And in the toddler group, or even in the neonatal or infant group, we may be using epinephrine as well. Dopamine is a very good drug. It's been used for many years in support of cardiovascular support for postoperative heart patients. But it is one of the drugs that we frequently use still in pediatrics compared with what's used in the adult world.
Great, thank you. So I see, and Tom, are you able to see the questions as well?
I am, yeah. So I'll take the first question. It says, just wondering if the doctor sees the PEDS unit doing more of the approaches with an OPO as support, or is it the other way around? And I take this question to really mean approaching families about donation, and I think it needs to be a coordinated approach. The approach of families in pediatric units is different. The intensive care team is very involved with the family, and we have to be because we're dealing with a minor. We have to get consent or authorization for everything that we do, and we have to explain everything that's occurring as we treat those children. And from that standpoint, parents trust the physician at the bedside because they have more interaction with them. I think it's important for us to understand that as we transition from trying to save a life to end-of-life care and a patient who's dying, our team members change. The intensivist, the palliative care specialist, and in fact the donation coordinator, I think, is an important part of that team that works with people at end of life, and how you actually put that team together and develop that rapport with the family becomes really important. I really work to try and talk to the family about a different team that's going to be working with them because their child is now facing end-of-life issues. And as we stepwise approach things, we begin to introduce those people. I think that the question always comes up with the donation coordinator and the intensivist, who should approach the family. And it's not about who, but it's about the team that approaches the family. The coordinator is sure that the intensivist is going to talk to the family about donation, and the intensivist fears that the donation coordinator is going to talk to the family about donation without involving one another. And the fears are the same, so why don't we approach together? Because the donation coordinator understands organ donation. They can answer those questions. The intensivist understands care for the dying child, management of organ systems. So I would really encourage teams to work together. The analogy that I always bring forth is that, when you take your child to the doctor and you trust your doctor and your child's sick and all of a sudden the child has to be admitted and you're seeing the nurse practitioner, it's not that you don't trust the nurse practitioner. You want to hear it from the doctor, the person that you trust. And so what I would say is, put yourself in a parent's shoes. The team that you would want taking care of your child in the intensive care unit is exactly that same team. So just think about it in those terms. But I always favor a combined approach because it's the combination of expertise that makes us successful in donation. Let's see.
Great,
the next question. Are there references
if you don't mind, I want to add to that.
Yeah, go ahead.
If you were to give me the next question actually, if you were to tell me I was going to choose one number to be normal in my body, I would want it to be the SVO2. And I think that's a great question. The question is, has continuous monitoring of SVO2 equated to an increase in organ recovery yield in the pediatric population? And I wonder if, you mentioned if that's normal, then you can maybe be a little bit less restrict or less strict on your donor management goals. You can tolerate a lower blood pressure if your SVO2 and or other tissue or markers of tissue perfusion are normal. Should SVO2 be a donor management goal, or should that be incorporated? And again, this is the question to answer from the audience. Has it shown to be related to an increase in organ recovery in kids?
So it's a very good question. I'm not aware that's been shown to actually result in higher organ recovery yield in the pediatric population. When we look at SVO2, you have to look at where that sample is being drawn from. So many times we're using femoral venous catheters, the shorter catheters, and the question is it a true SVO2 value compared to having something that's sitting up in the superior vena cava, the atrial junction there? And I don't necessarily know the answer to that. I think SVO2 is one of those parameters that you can follow along with lactate, along with near-infrared spectroscopy. We don't always have the luxury of having a central line in some of our kids just because it's really difficult to cannulate some of these smaller kids. Or some of these children have chronic disease processes and it makes cannulation of central vessels very difficult as well. So to answer that about SVO2 monitoring, if you have it and it's available, yes, I follow it. Is it a necessity for me to determine whether or not organs are being perfused adequately in the patient? Not necessarily, because I may have other things that I'm following, such as near-infrared spectroscopy or serum lactate levels. And again, serum lactate levels don't always tell the full story either, because you have to understand what that number is trying to tell you. The lactate could be high because you have liver dysfunction and you're not metabolizing lactate, or you have dead tissue, when in fact your oxygen delivery to the tissues may in fact be normal.
Sure. Yeah. Excellent response. Thank you. And another question: are there any references for the combined use of vasopressin and desmopressin in DI?
Not that I'm aware of. Unfortunately, I think most people go for vasopressin first, and if you're having problems controlling DI because it's refractory DI, then they'll move to vasopressin. So it just depends. It's personal preference. The one thing I will say is desmopressin should not be given intranasally. It needs to be given IV. And again, donor management protocols, pediatric donor management drug dosing guidelines are available and provide dosing for desmopressin in those instances.
Right. All right. And to quickly get back to the SVO2 question, follow-up, is the NIRS superior to SVO2 monitoring for assessing tissue perfusion, if you have access to that?
I can tell you that just anecdotally dealing with a lot of cardiac patients, you'll see the NIRS respond faster than you will SVO2 sometimes. And I recall a patient that actually developed a pneumothorax, and the NIRS dropped dramatically. And we were trying to figure out why the NIRS dropped dramatically. And it dropped much faster and alerted us before the SVO2 started to fall. So yes, in that way it may respond faster. I don't know if it's necessarily superior, but it's just another non-invasive method that we have to try and determine whether or not tissue oxygenation is reasonable.
Okay, thank you. And next question, how do you work with a potential donor who is unstable or too hemodynamically unstable to declare brain dead? Would you be moving for cerebral blood flow or tolerate or try to tolerate an apnea test, or do you just pursue DCD at that point?
Sure. So that's actually a really good question. How do we deal with that? If the patient or if the donor, potential donor, it's actually a patient at that point, if the patient is too hemodynamically unstable to make a declaration of death because you can't do an apnea test, then you're going to have to do a flow study. And if they're too unstable to move to a flow study, then the bottom line is you're not going to be able to declare neurologic death. If you can't declare neurologic death, you can always pursue DCD donation, absolutely. And there are cases like that. There are cases in the literature, cases I've been called about, talking about the brain death guidelines, and, it's just like there needs to be provisions for that where we don't need to do the apnea test. It's just not going to happen. Coma and apnea have to coexist, and if you begin to bend the rules, and everybody bends the rules, there's a very specific protocol that we work through in an effort to try and standardize what we need to do. And it's important that people understand that the guidelines for determination of neurologic death are the minimum guidelines. So if you can't meet the minimum guidelines, then you really need to take a step back and say, gee, we can't declare brain death if you can't even meet the minimum criteria. So I would just move forward and pursue DCD donation in that case.
Sure, okay. And it's safe to say, I think I've heard you say this in some of your presentations before, that cerebral blood flow is in and of itself definitive. Or a negative,
yeah.
A negative CBS.
It's the best that we have. It is the best that we have. Yes.
Right. All right. And last question that I see so far, what is your advice to hospital staff regarding what the triggers are to refer a potential pediatric DCD donor?
I think that DCD and brain death are the same way. If you are having discussions about end-of-life care, withdrawal of medical therapies, if you are entertaining DNR status, or if you are even contemplating brain death examination, then you should be calling, making that early referral. I am a pretty staunch advocate that if you are calling after the first brain death declaration, that's a late referral. We need more time to sit down and work with these families. So, again, if you're having discussions about end-of-life care, I think that's the time that you need to make the call. And it may be that you'll meet clinical triggers before that, which is fine, but that's the latest time that I would call if you're beginning to talk about end-of-life care. Right,
great. And I think that emphasizes your point that organ donation now is really an appropriate component of the entire discussion of end-of-life care. So, Deanna, that's all the questions that I see, and I'll turn it back over to you for any final.
No, I'm not sure where Deanna is, but I will take over and just say thank you again to Dr. Nakagawa and Dr. Sellers. Thank you so much for sharing your great information, and want to thank everyone for your participation today. Have a great